Welcome to this module where I talk about anti-hyperglycemic agents used to control glucose levels in people with diabetes. I'd like to start by acknowledging with gratitude that this presentation was created on the unceded and stolen homelands of the Musqueam, Squamish, and Tsleil-Waututh First Nations, and to thank them for their stewardship of these beautiful lands. So in this module, I'm going to review the current anti-hyperglycemic agents that are available in Canada, or AHAs for short, and choosing the right AHA for the right patient. So I've got a few case studies in here as well. So the history of AHAs, I had to add a few things in here because the chart didn't go back in time, and you can see that we had sulfonylureas as far back as 1969, and metformin's been around since 1972. And then we have another agent added in since 2022, tirzepatide. So you can see how each one of these agents has been brought to the market and giving us some options in managing diabetes. So BC Pharmacare coverage for AHAs and glucose testing supplies currently are that they will cover glyburide and metformin, and you have to fail on glyburide in order to start gliclazide, and I believe that's lightening up a little bit now where they're not insisting on that, but their special authorization form is required for dapagliflozin, empagliflozin, linagliptin, saxagliptin, and semaglutide, which is Ozempic as well. And they'll supply lancets and blood glucose and ketone and urine testing strips, but that is after they have taken a couple of classes to provide some diabetes education at an authorized center, so usually a diabetes health center. And then continuous glucose monitors, things like the Dexcom or Libre, are covered for those taking 4 injections of insulin a day or on insulin pumps, and they do require a special authorization form. So here's just a general list. Anything that is in yellow is covered with no restriction on BC Pharmacare, and the remaining blue, you do require some special authorization or proof that you have not been successful on the ones in yellow. And of course, these are all for people with type 2 diabetes because if you have type 1 diabetes, you're on insulin. So I'm just going to go through each of the classes and briefly cover who they are, what they do, and what we need to watch for. So glyburide, gliclazide MR, and repaglinide or glucanorm are the sulfonylureas that will push the pancreas to put out more insulin. They are indiscriminate in that they will push whether you eat or not, so they're not matched well, and there is a high risk of hypoglycemia when we give these agents and a person doesn't eat. There's also a higher risk in elderly patients and those with impaired renal function because it holds in their system a lot longer, and they can cause weight gain, which is not something we want to add if they have that problem already. The considerations are that you want to give them 30 minutes before eating, which is sometimes a bit of a challenge because they'll take it first thing in the morning and maybe not have breakfast for a while. Don't give it if they aren't eating. If they're NPO or not eating well, they shouldn't take these pancreas pushers, and we need to watch for hypoglycemia and counsel them on how to recognize the signs and symptoms and treat it, as well as hypoglycemia and driving guidelines. The Bigonide, the only one available is metformin or glucophage, Glumetza, different names there. And it's a great drug, been around since 1972, and it decreases the amount of glucose released by the liver because sometimes that's a problem in type 2 diabetes where the trigger for hypoglycemia triggers the release of glycogen from the liver, and it will overreact and send too much glucose into the bloodstream. It also increases sensitivity to insulin, making its own insulin that they're producing work better. So it decreases the resistance, and this is in the liver and the muscles. The side effects are they could have diarrhea, especially if they start the drug too fast and titrate up too quickly. They can have some digestive problems, metallic taste in their mouth, but it is an appetite suppressor, very mildly, nothing compared to the Ozempics and Mounjaros that are around now. And we are not supposed to use in renal or liver insufficiency. Those guidelines have kind of eased up a little bit in that the EGFR that we normally would have stopped someone many years ago on metformin, we would have stopped them at an EGFR less than 60, is now been reduced to use with caution, and you can use it to an EGFR of 30. Titrate the dose slowly to avoid that gastric side effect, and watch for vitamin B12 deficiency as well. SGLT2 inhibitors. So these are the gliflozins, canagliflozin, dapagliflozin, empagliflozin, or Invokana, Forxiga, and Jardiance. So what this does is block the reabsorption of glucose in the renal tubules, which means that the glucose gets peed out. So they actually excrete their glucose in the urine instead of bringing it back into the system and raising the blood glucose levels. But the problem is, since glucose is osmotic and takes fluid with it, if you are getting rid of this glucose in your urine, you can have dehydration. So they do need to drink a fair amount every day, usually 1 liter to 1.5 liters. They could also have frequent urinary tract infections and yeast infections due to the higher glucose concentrations in the urinary area, and then of course in ladies the yeast infections because it's all in the same area, and good fluid intake. So we need to, this drug has actually become quite a popular and proven to be a good drug for people. So the indications have expanded to include those with renal impairment and cardiovascular disease. It rarely causes hypoglycemia because you are waiting till the sugar level is over about 7 before it will spill over into the urine and get rid of that extra glucose. But we need to watch for euglycemic, which is relatively normal sugars, and DKA in type 2. So I've had people come into hospital with sugars of 12 and they're in DKA and they have type 2 diabetes. And that's because when they were sick, they didn't stop taking the drug and they kept, they were not able to keep the fluid intake up, or the, and it built up in their system. So it is not for use for patients with type 1 diabetes or those on keto diets as well. DPP-4 inhibitors, so they're a little more expensive and they actually are falling a little out of favor. They only reduce the A1C by about 0.5%, and we have better drugs now. So we're really not seeing them like jumping all over them when we have better agents. And if a person's got pill fatigue, they're going to want to choose the ones they take. So sitagliptin, saxagliptin, linagliptin, or Januvia, Onglyza, Tradjenta are the DPP-4 inhibitors. And what they do is stimulate insulin secretion and decrease the glucagon release from the liver in a glucose-dependent manner, meaning they don't cause hypoglycemia. And DPP-4 increases the level of GLP-1, which is Ozempic, Mounjaro, and it allows more insulin to be released. So the side effects are that we have reduced risk of hypoglycemia, but it can cause mild nausea and dizziness, and there are some mild weight loss properties to this. It's very unlikely to cause hypoglycemia because it doesn't trigger the release of insulin until the glucose rises in the blood. It is glucose dependent. And so there are some recommendations here for surgery, and this was vetted through the endocrinology team, that if they're taking an oral, like an antihyperglycemic agent, like repaglinide, a pancreas pusher, or sulfonylureas here, we want to omit the morning dose, but because repaglinide is such a short-acting pancreas pusher, they could actually take the dose right after, when they're eating breakfast before 7:30, but then go for their procedure. The long-acting sulfonylureas, glyburide, glycoside, and glimepiride, we want to omit those on days that they're in PO. Metformin, great drug. They may need to stop it just because it can give a little gut rot, but most of the time they just say day before we can take all of these drugs listed as normal, and the morning of the dose, morning of the surgery, they may just omit a lunch dose if they're on TID. The zolidiones, rosiglitazone, pioglitazone, you will not see them very often now, so probably not going to come across your plate. The DPP-4 inhibitors and the GLP-1 analogs, which would be mostly the Ozempic, Mounjaro, they can take that as normal. And the SGLT2 inhibitors, we should omit on surgery for surgical procedures. So here's a case study of Josephine. She's 72 years old and she's admitted to the medicine unit after experiencing a fall at home. She lives alone and she's been struggling with frequent falls. So her current medications are metformin, and this is the maximum dose we typically prescribe, 1,000 milligrams POBID. Even though we can prescribe up to 2,500 milligrams a day, the increased risk of side effects for the extra 500 milligrams does not produce the benefits, and so we go to a second agent before we would bump up that metformin to the maximum dose. And she's on glyburide, 10 milligrams POBID. So you can see here at breakfast, the sugars are kind of drifting in the lower range, and really all day long she's kind of okay, but skirting in the low range. And so she's 72 and living alone. So would you administer her AHA medication this morning, her metformin and her glyburide? Would you give that to her when she's sitting in the fours and has a history of frequent falls? That might not be a great idea. This might be something she needs to revisit with the prescriber. She's booked for a colonoscopy in 2 days, and she's going to start her bowel prep, which means she'll be MPO and she's going to be voiding a lot and under a lot of stress. So do you have any concerns with giving her her metformin and glyburide during this bowel prep? And should you talk this over with the prescriber? So I would definitely be talking with the prescriber about this, and these might be drugs that we're not going to give during the bowel prep period, especially the glyburide. Risk it falls, running low in terms of the glucose levels, and she's 72, living alone, and we have real concerns over that fall risk. So we have Harold here. He's 59-year-old, and he's admitted with atrial fibrillation, and some of his liver function tests are high. His A1C is 6.4%, and the physician has sent blood work as they're concerned about liver disease. So he's had type 2 diabetes for 14 years, and he takes metformin, the maximum dose we would give, gliclazide MR, the maximum dose we would give, 60 milligrams POBID, and he's on empagliflozin, the maximum dose we can give. That's the SGLT2 inhibitor that allows him to pee out his extra sugar, and he's on 25 milligrams POQAM. He's been struggling with hypoglycemia, at least, and that's usually at lunch, at least 4 times a week. So when you take a look at this list of AHAs, which ones would you pick out as being contributing to hypoglycemia? So think about that for a moment. And if you look at that, the ones that will cause hypoglycemia, it is gliclazide MR. That's the pancreas pusher. His A1C is 6.4%, which is lovely, but not if he's having lows all the time. And are there any other medications that might not be appropriate to use in liver disease? And if you had seen the chart and were paying very close attention, you would see that metformin is actually not advised to be given in liver or renal disease. So that would be one we would reconsider as well. And perhaps we put him on something like a GLP-1. And there is a separate module for GLP-1s explaining that in this series. And now we have Sophia. She's an 82-year-old female living at home alone. Her A1C is 8.4%, and she's had type 2 diabetes for 2 years. She's on metformin, maximum dose, gliclazide MR, maximum dose. So instead of splitting it twice a day, they put the 120 milligrams once a day in the morning. And she's been resistant to taking her medication on a regular basis, so she's not very consistent. So if we take a look here, her breakfast, running a little bit high, I would say. We don't want them in the teens for sure. Now she's 82, so we're going to flex our targets a little bit for her, living alone. Her lunch is running to go from 13 or 14 down to 5 or 6. Is a concern, because that means there's way too much action in her medications, bringing her lunch down that low. And then supper is drifting definitely in the too low range for her. And then she bounces back up at HS. And so do you think she needs any adjustments to this? And I would say she definitely does. And what time of day are their problems? Well, we identify definitely supper is a big problem, and definitely breakfast. We might accept glucose levels of, kind of a range of 6 to 12 for her. So I'm not too worried about the ones that are drifting in the 12, 13 range. But what might you suggest here? Metformin and gliclazide. So she has no contraindications for metformin, and it won't cause hypoglycemia. So that's probably safe to continue with. But she definitely, as an older adult, should not be using a sulfonylurea. And we should put her on something like it could be a DPP-4 if they chose, or definitely an SGLT2 inhibitor. That would be a safer way to go, lower risk of hypoglycemia, and she's got better bang for her buck in terms of the reduction in the A1C. And then we have a rash here. He's a 78-year-old man with type 2 diabetes for 15 years. His A1C is 5.4%, which, wow, that's normal. Anything below 5.6 is actually considered a normal A1C. He's experiencing low blood sugar episodes at least 3 times a week. So he's currently on metformin maximum dose and glyburide maximum dose. So what are we looking at here? Which of his 2 AHAs can cause hypoglycemia? And if you guessed glyburide, you guessed right. So that is the one, the offender, and he's got some that are drifting quite low, and it looks like with an A1C of 5.4%, he's actually too low for our liking here. We don't know if he drives. He's at risk for hypoglycemia when he's driving. Is the A1C target appropriate for him? He's a 78-year-old fellow. So we have to balance out what complications are we going to prevent in an older adult versus what complications will happen if he has a fall and breaks his hip or low blood sugar while driving. So an appropriate target for him would be at least 6%. That is still beautifully safe. It might be less than 7% that we're looking for. So what might you suggest to limit his time in a hypoglycemic state? And I think we talked about removing the glyburide and putting him on an SGLT2 inhibitor, which is much more safe and much less risk of hypoglycemia. And then our final case study is Kim. She's an 85-year-old woman with type 2 diabetes for the past 24 years. Her A1C is 7.6%, her eGFR is 74, and she's currently on Ozempic or semaglutide at 1 milligram once a week, and she's on an SGLT2 inhibitor, empagliflozin, 10 milligrams, which is a very common dose. We don't often go to 25 anymore. They used to, but they're starting to realize they can get the same efficacy at 10. So let's see, breakfast. They look like fantastic blood sugars, don't they? That's quite nice. So are there any issues with her glucose control? She's having no lows. She's having no highs. Her A1C is 7.6. She's 85 years old. She's not having any hypoglycemia or any falls or any concerns. We don't need to do a thing here. So we can just leave things as is, which is kind of a nice thing to do, not to have to intervene. So the key messages are there's a variety of AHAs and non-insulin injectables that can fit the person's needs. There is no one right drug. It depends on individual needs, their access to it, the cost, and the risk of hypoglycemia. And AHAs can be used together with insulin and or the dual agents and GLP-1s. It's not necessary to hold medications that don't cause hypoglycemia when the person has low glucose levels. An SGLT2 inhibitor is not going to cause hypoglycemia, so it could continue to be given. And that's important for those of you working in the hospital, is that we tend to just hold everything that has to do with diabetes, but some of these, like the Ozempic or the SGLT2s, don't need to be held. They are an excellent tool in diabetes management, but we need to use the right drug in the right patient situation. Thank you for your time.